valvular heart disease and especially on aortic stenosis. For your kind information, we'd like to inform you that there are 4 types of valves in our heart: aortic valve, mitral valve, pulmonary valve, and tricuspid valve. And among these 4 types of valves, some diseases are very common, and the names of the diseases which are very common include stenosis, regurgitation, prolapse, and atresia. Here on this topic, on this class, so in this class, we are going to talk about aortic valve stenosis. And valvular heart disease, we will be talking about aortic stenosis. There are some topics here: aortic regurgitation, mitral stenosis, transcatheter aortic valve replacement, endocarditis, and endocarditis prophylaxis. But now we are going to only talk about aortic stenosis, and the writers are Geoffrey D. Huntley, MD, Fellow, Department of Cardiovascular Medicine, Mayo Clinic, Rochester, Minnesota, United States of America. And the other second writer is Jeremy J. Hayden, MD, Assistant Professor, Department of Cardiovascular Medicine, Mayo Clinic, Rochester, Minnesota, USA. And the third writer is Vuisail T. Nokomo, MD, MPS. Currently, he is Professor of Medicine, and he is Director, Valvular Heart Disease Clinic, Department of Cardiovascular Medicine, Mayo Clinic, Rochester, Minnesota, United States of America. So this is the introduction of the writers, of the 3 honorable writers. Now we are going to talk about aortic stenosis. Total 60. We will be talking about 16 questions and the answer to those 16 questions. I hope you will be with us during this lecture. This lecture will help you in understanding English, and this lecture will also help you to be a little bit aware about valvular heart disease or heart diseases of the valve in our heart. Question 1: What is the prevalence of aortic stenosis? What are the trends in aortic stenosis with age? Answer is aortic stenosis is the second most common valvular heart disease in the community and the most frequent single valve disease referred to the hospital. It has been estimated to occur in 0.3% to 0.5% of the general population and 2% to 7% of individuals older than 65 years of age. The prevalence of severe AS or aortic stenosis for which intervention should be considered may be as high as 3% to 4% in older adults more than 75 years of age, 1% to 2% in persons aged 75 to 76 years, and up to 6% in those aged 85 to 86 years. The number of patients aged 75 years or older with aortic stenosis is expected to double in the next 2 to 3 decades as life expectancy increases across the globe. Question 2: What are the risk factors for and common causes of aortic stenosis? In the developing world, rheumatic heart disease remains the most common cause of aortic stenosis. In developed countries, progressive calcification of tricuspid or bicuspid aortic valve, so-called calcific degenerative aortic stenosis, represents the most common mechanism. The prevalence of a congenitally abnormal bicuspid valve as is present in up to 2% of the population, or more rarely a unicuspid or quadricuspid valve, predisposes to the development of calcific aortic stenosis due to abnormal valve geometry and mechanical stress. A bicuspid aortic valve is the most common valve morphology of aortic stenosis in individuals up to the seventh decades of life. NISSY 8 for high. Okay, you are also welcome to the live conversation on aortic stenosis, aortic valve. There are 4 types of valves in our human heart: aortic valve, mitral valve, pulmonary valve, and tricuspid valve. And there are commonly 4 diseases that affect the valve of our heart, and the diseases are stenosis, regurgitation, prolapse, and atresia. So in this lecture, we are going to be talking about aortic stenosis. A bicuspid aortic valve is the most common valve morphology of aortic stenosis in individuals up to the 7th decades in life. A bicuspid aortic valve is the most common valve morphology of aortic stenosis in individuals up to the 7th decades of life. General risk factors for aortic stenosis are similar to those of atherosclerosis, such as age, hyperlipidemia, hypertension, diabetes, smoking, and renal dysfunction. Question 3. What is the pathobiology and pathophysiology of aortic stenosis? Though aortic stenosis is sometimes called degenerative, the underlying pathology is an active process similar to atherosclerosis, involving lipoprotein accumulation, cellular infiltration, inflammation, and extracellular matrix formation. Progressive calcium deposition and ossification results in progressive cast immobility and obstruction to flow. Aortic stenosis exerts a pressure overload on the left ventricle, or simply LV. Normally, pressure in the left ventricle and aorta are similar during systole, as the normal aortic valve permits free flow of blood from left ventricle to aorta. However, in aortic stenosis, the stenotic valve forces the left ventricle to generate higher pressure to force blood through the stenotic orifice, causing a pressure difference or gradient from the left ventricle to the aorta. The LV compensates for this pressure overload with progressive increase in LV, or left ventricle wall thickness, or LV hypertrophy, or left ventricle hypertrophy, or LVH. Chronic aortic stenosis may lead to significant left ventricle hypertrophy and myocardial fibrosis, ultimately leading to impaired myocardial compliance and diastolic and systolic heart failure. Question 3. What are the symptoms of aortic stenosis? The classic symptoms of aortic stenosis are dyspnea, syncope, or angina. Dyspnea occurs due to either increased left ventricular filling pressure or inability to increase cardiac output with exercise. Reduction in cerebral perfusion leads to dizziness and syncope. With progressive LV dysfunction, reduced stroke volume, and impaired myocardial compliance, many manifestations of heart failure appear. Exertional angina is more common in patients with concomitant coronary artery disease. Onset of symptoms may be subtle in inactive patients. However, once a diagnosis of severe aortic stenosis is firmly established, even mild cardiac symptoms carry prognostic importance as symptom onset is associated with an average survival without aortic valve replacement or AVR of only 2 to 3 years, and there is an increased risk of sudden death. Question 5. What are the physical examination signs of aortic stenosis? Physical examination findings in severe aortic stenosis. In mild disease, the murmur peaks in intensity early in systole, but as severity of disease increases, it peaks progressively later. The carotid upstrokes become delayed in timing and reduced in volume because the stenotic valve steals energy from the flow of blood as it passes the valve. Because the severely stenotic valve barely opens, there is little valve movement upon closing. Thus, the A2 component of S2 is lost, rendering a soft single second sound. It is important to note that the lack of physical examination findings should not dissuade suspicion if history, symptoms, and imaging are strongly suggestive of AS. For example, a harsh murmur may not be present in a patient with low forward flow or large body habitus, and stiff vasculature in the elderly or patients with chronic kidney disease may result in normal carotid upstroke despite severe aortic stenosis. Question 6. What is the natural history of aortic stenosis? The commonly accepted paradigm of aortic stenosis and symptoms is represented. Typically, early disease is relatively benign, but symptom onset marks the date for prompt evaluation for intervention. Asymptomatic patients with normal left ventricular systolic function who have no change or in signs or symptoms who have re-evaluation with echocardiography every 6 to 12 months for severe aortic stenosis. 1 to 2 years for moderate aortic stenosis and 3 to 5 years for mild aortic stenosis. The rate of progression of AS or aortic stenosis is variable, but once moderate aortic stenosis is present, on average the transvalvular velocity increases by 0.1 to 0.3 meter per second per year. The mean pressure gradient or mg increases by 3 to 7 mmHg per year, and the valve area decreases by 0.1 square centimeter per year. Risk of sudden death in the asymptomatic phase is relatively low at 1% per year, and risk of mortality increases dramatically with the start of symptoms, with event-free survival of 30% to 50% at 2 years. Progression to severe aortic stenosis and need for AVR, aortic valve replacement, is universal. Question 7. What is the role of echocardiography in aortic stenosis? Echocardiography is the central tool in assessing the presence and severity of AS or aortic stenosis. Primarily, transthoracic echocardiography is utilized to define aortic valve anatomy, number of cusps, extent of calcification, and degree of leaflet restriction. Valve hemodynamics to grade severity, the consequences of left ventricular function and remodeling, left atrial size, and the presence of concomitant root or ascending aortic pathology or other valve pathology. Doppler echocardiography uses basic principles of physics to quantify stroke volume and transvalvular gradient, and to derive the aortic valve area. Forward stroke volume can be measured through the LV or left ventricular outflow tract, or LVOT or LVOT. By multiplying the LVOT or left ventricular outflow tract cross-sectional area derived from the diameter by the LVOT or left ventricular outflow tract velocity time integral VT IOT. The stroke distance or distance blood travels with each ejection. As the AVA decreases, velocity of flow must increase for flow to remain constant. Flow is equal to area multiplied by velocity. Question 8. How is aortic stenosis graded by echocardiography? Aortic stenosis is now graded as mild, moderate, severe, or very severe. Criteria for each grade or category are given in this book in a chart or a table. What is the role of exercise stress testing in aortic stenosis? Exercise stress testing can be used for risk stratification in asymptomatic patients with severe aortic stenosis and left ventricular ejection fraction or LVEF equals 50% or more than 50% by echocardiogram. Peak velocity more than 4 meter per second or equal 4 meter per second, or mg more than 40 mmHg or mg equals 40 mmHg. Up to 1/3 of patients who are reportedly asymptomatic will develop symptoms with stress. Hypotension with exercise or exercise induced symptoms at up to 1/3 of patients who are reportedly asymptomatic will develop symptoms with stress. Hypotension with exercise or exercise induced symptoms at a low workload portend a significantly worse prognosis and should prompt a discussion of aortic valve intervention. If the exercise test is normal, short-term prognosis is assumed to be reasonable and follow-up can be continued as discussed in question 6. Because of the risk of sudden death, exercise stress testing in patients who have symptomatic aortic stenosis or have LVEF or left ventricular ejection fraction less than 50% is contraindicated. Question 10. How do you assess aortic stenosis severity in a patient with discordant small aortic valve area and low mean gradient? As severe aortic stenosis severity may be challenging to define in some patients, particularly when the mg is less than 40 mmHg, low gradient, but the AVA suggests severe stenosis less than 1 square centimeter or equals square centimeter. Low flow physiology. Low flow physiology is an important cause of low gradient aortic stenosis and can occur as a result of reduced left ventricular ejection fraction less than 50%, but may also occur with preserved left ventricular ejection fraction more than 50% or equals 50%. In patients with small LV or left ventricular cavities, severely impaired left ventricular filling from advanced diastolic dysfunction, atrial fibrillation, other concomitant valvular diseases, or constrictive pericarditis, among others. Flow influences gradient, so low flow state may lead to underestimation of aortic stenosis severity based on the transvalvular velocities and pressure guidelines, while on the other hand, the AVA may be falsely low and overestimate the severity due to decreased cuffs opening in patients with severe left ventricular dysfunction. The echocardiogram should be reviewed to ensure that there is no measurement error, underestimation of stroke volume, suboptimal Doppler alignment with underestimation of gradient, etc., a small body surface area, which could account for these findings. Once low gradient aortic stenosis is confirmed, in patients with left ventricular ejection fraction equals 50% or more than 50%, computed tomography or CT aortic valve calcium score can be helpful to differentiate moderate to severe aortic stenosis. Aortic valve calcium score more than 2000 Agaston units or equals 2000 Agaston units or AU in men, and more than 1200 AU or Agaston units or equals 1200 Agaston unit in women suggests severe aortic stenosis. If left ventricular ejection fraction is less than 50%, contractile or flow reserve should be assessed with low dose dobutamine echocardiography to differentiate between severe aortic stenosis, stroke volume increased by 20% or more than 20%, and mg is 40 mm Hg or more than 40 mm Hg with AVA of less than 1 or equals 1 square centimeter, and moderate or pseudo severe aortic stenosis, mg less than 40 mm Hg and or AVA more than 1 square centimeter with normalization of stroke volume. Question 11. What is the role of cardiac catheterization and computed tomography in aortic stenosis? Cardiac catheterization is indicated when non-invasive data are non-diagnostic or when physical examination data are discordant with echocardiograph findings. Pressure differences across the aortic valve are measured using simultaneous pressure measurements of the left ventricular and aortic outflow tract. AVA can also be calculated with the catheterization using cardiac output derived from peak or thermodilution measurements. AVA square centimeter is equal to cardiac output L by minute, liter by minute, divided by square root of peak to peak gradient across the aortic valve. This invasive strategy crosses a calcified stenotic valve and rarely may cause calcific debris, embolization or injury to adjacent structures such as the coronary ostia or aortic annulus. CT or computed tomography is increasingly used as an alternative method to determine aortic stenosis severity. Since calcium deposition is the predominant process in valve obstruction, CT aortic valve calcium scoring can be useful in diagnostic dilemmas such as low gradient aortic stenosis where the severity of stenosis is uncertain. A calcium score of less than 700 AU excludes severe aortic stenosis with a high negative predictive value, while a score of equals or more than 2000 AU in men and equals or more than 1200 AU in women suggests severe aortic stenosis. In addition, increasing aortic valve calcium independently predicts mortality in medically treated patients with aortic stenosis and thus can be useful when considering timing of AVR. Lastly, CT is used to acquire additional anatomic data such as prior to transcatheter aortic valve implantation or TAVI, where it is utilized for valve sizing and to assess the suitability of arterial access for a transcatheter approach. Question 12. What is the prevalence, what is the significance, and what is the physiologic sequelae of concomitant atrial filtrate fibrillation in patients with severe aortic stenosis. 1/3 to 1/2 of patients with severe aortic stenosis also have atrial fibrillation. Atrial fibrillation and aortic stenosis often coexist as they are both common with aging, and atrial fibrillation may be a consequence of atrial stenosis. Valvular obstruction and left ventricular hypertrophy in aortic stenosis lead to diastolic dysfunction and elevated left atrial pressure that precipitates atrial fibrillation. On the other hand, since AS or aortic stenosis is physiologically dependent on diastolic filling and stroke volume, the loss of a coordinate left atrial contraction in atrial fibrillation may further reduce preload, stroke volume, and cardiac output and lead to symptoms of heart failure and syncope. These effects are exacerbated in the setting of atrial fibrillation with rapid assessment of aortic stenosis in patients with atrial fibrillation can often be challenging, and atrial fibrillation is common in low gradient aortic stenosis. Importantly, beat-to-beat variation in stroke volume in patients with atrial fibrillation may lead to lower transvalvular flow and velocities and underestimation of aortic stenosis severity, making alternate measures of aortic stenosis, such as CT calcium score, necessary. In addition, high single beat Doppler signals meeting criteria for severe aortic stenosis in patients with atrial fibrillation and low gradients may indicate true severe aortic stenosis and should prompt comprehensive evaluation for severe aortic stenosis when present. Lastly, preoperative atrial fibrillation is a predictor of postoperative mortality and morbidity after AVR. Question 13. What medical therapies are effective in the treatment of aortic stenosis? What is the risk of mortality in severe symptomatic aortic stenosis managed medically? There are no effective medical treatments for aortic stenosis. There are no effective medical treatments for aortic stenosis. Although lipid metabolism is thought to be involved in the pathogenesis and progression of aortic stenosis, several trials have failed to document an effect of lipid-lowering therapy on pathogenesis and progression of aortic stenosis. Several trials have failed to document an effect of lipid-lowering therapy on aortic stenosis progression. The only proven role of medical therapy in aortic stenosis is symptom management. However, in patients with severe aortic stenosis and decompensated heart failure, medical therapies such as vasodilators, diuretics, and inotropes must be used with caution and close hemodynamic monitoring. The only effective treatment for severe aortic stenosis is AVR, aortic valve replacement. And medically managed severe aortic stenosis may carry a risk of mortality of 50% at 2 years, comparable to many malignancies. Balloon valvuloplasty does not change the natural history of severe aortic stenosis, but may have limited utility as a bridge to more definitive valve intervention in rare cases. Question 14. When is aortic valve replacement indicated in aortic stenosis? When considering AVR or aortic valve replacement for aortic stenosis, the following should be taken into account. Patient's symptoms, severity of aortic stenosis, left ventricular ejection fraction, and need for other cardiac surgery. as for example, coronary artery bypass grafting, summarize indications for aortic valve intervention in aortic stenosis based on the 2020 American College of Cardiology or American Heart Association guidelines. Important class 1 indications that is indicated or recommended for aortic valve replacement are symptomatic with high gradient severe aortic stenosis, recommendation class 1, level of evidence A, low flow, low gradient severe AS with left ventricular ejection fraction less than 50%, 1B, low flow, low gradient severe AS with normal LV, EF or left ventricular ejection fraction, and aortic stenosis is most likely cause of symptoms, 1B, asymptomatic with severe aortic stenosis and LV, EF or left ventricular ejection fraction less than 50%, 1B. Severe aortic stenosis and undergoing cardiac surgery for another indication, 1B. AVR or aortic valve replacement is reasonable in asymptomatic patients with low surgical risk and a positive exercise test, stress test, 2AB, very severe aortic stenosis, 2AB, elevated serum B-type natriuretic peptide levels, 2AB, or an increase in aortic velocity more than or equals 0.3 minute per second per year on serial testing, 2AB, AVR or aortic valve replacement is not indicated in life if life expectancy is less than 1 year and palliative care should be pursued or given. Question 15. Question 15. What are the indications for surgical aortic valve replacement versus transcatheter aortic valve implantation? Based on the 2020 or 2020 American College of Cardiology or American Heart Association guidelines, when aortic valve replacement is indicated, the first step is deciding one on valve prosthesis type, mechanical versus bioprosthetic, a choice that should be based on a shared decision-making process between the patient and a multidisciplinary heart team. Mechanical prostheses are more durable but require indefinite anticoagulation with vitamin K antagonist, while bioprostheses have a higher rate of valve deterioration and may require re-intervention. When a bioprosthetic and aortic valve replacement is appropriate, the heart team and patient must make into account the patient's age and life expectancy, values, surgical risks, and anatomy when choosing between surgical AVR or SAVR and TAVI. In symptomatic and asymptomatic patients who are less than 65 years of age or have a life expectancy of more than 20 years, SAVR is a class 1 recommendation. Conversely, on the other hand, TAVI or TAVI is a class 1 recommendation for patients who are more than 80 years of age or have a life expectancy of less than 10 years and have no contraindication to transfemoral access. Either SAVR or TAVI is recommended for symptomatic patients with severe aortic stenosis who are 65 to 80 years of age with no anatomic contraindication to TAVI or TAVI class 1A recommendation. The use of TAVI may expand in the future, but more data are needed on the long-term durability of TAVI and the use of TAVI in patients less than 65 years of age. Last question, and question number 16. This is the last question on the chapter aortic stenosis. Stenosis means when your valve aorta becomes stenotic, that means becomes narrow. Stenosis means narrowing, and aortic stenosis means narrowing of the valve aorta or aortic valve. Question 16 and the last question of our session. What are the outcomes for aortic valve replacement? What are the results of the aortic valve replacement? What are the most common complications of transcatheter aortic valve implantation? AVR or aortic valve replacement relieves symptoms, enhances capacity and quality of life, improves left ventricular systolic function, and prolongs life expectancy. Long-term survival after AVR is excellent. Regardless of surgical risks, AVR in patients with severe aortic stenosis is superior to medical therapy. For elderly patients, survival is similar to ACE and census matched controls. Overall 30-day mortality after SAVR is less than 3% for isolated AVR, aortic valve replacement. In addition, TAVI has shown to be a safe and effective treatment for severe symptomatic aortic stenosis in all adults, regardless of surgical risks. Compared with SAVR, TAVI is associated with a shorter hospital stay and a lower risk of stroke, major bleeding, and atrial fibrillation, but higher rates of vascular complications, paravalvular regurgitation, and new pacemaker implantation. So that's all about aortic stenosis. Once again, I would like to repeat, human heart, there is only one heart in our human body, and the human heart, our heart has only four valves, and the names of the four valves are aortic valve, mitral valve, pulmonary valve, and tricuspid valve. And there are some common diseases which affect the four valves of the heart, and the common diseases are stenosis, that means your valve or heart or vein or artery becomes narrow. Regurgitation, that means it leaks back blood. And prolapse means it becomes longer or it becomes broader. And atresia means it becomes a little bit damaged or it becomes something like destroyed or something like destruction. So these are the four diseases: stenosis, regurgitation, and prolapse. And atresia affect our four valves in our human body, and the four valves are aortic valve, mitral valve, pulmonary valve, and tricuspid valve. And in this lecture, we talked about aortic stenosis. Stenosis means when your aortic valve becomes narrow or becomes narrowed. So I hope you did enjoy listening to this lecture. If you did enjoy listening to this lecture, please hit the bell icon and please try to be a subscriber to this channel. And wishing you all watching all other videos in this channel, because the channels are for education, and this channel is for education, and education is power, education is entertainment. So if you become entertained by education, by new knowledge, by something new, something extraordinary, something uncommon, please try to be a member of this channel, and please continue watching all other videos in this channel. Thank you. Wishing you all a good heart, good valve, and good health, good hygiene, and a good future. Thank you.